Is the recording? So, a very good evening. It's indeed heartening that WINCARS is again here for its monthly interventional meeting. And this time it's Dr. Hetan Shah who has organized this meeting. And of course, we all know that coronary intervention is now incomplete without all the imagings and the beautiful images, but of course, the images which serve the purpose of getting better results, better appositions, and less future complications. So, Dr. Hetan Shah is the organizing chair. I now hand over the session to her to introduce the chairs, the moderators for the session, and take over the meeting. All the very best.
Thank you. Thank you, Shiba, for giving such a wonderful opportunity for academic CME. And I think you only insisted me to present that. So thank you very much. And it gives me a lot of insight into the topic. This is a very hot topic of the day, like vulnerable plaque. And let me have a pleasure to introduce one of my dear friend and the senior consultant interventional cardiologist, Dr. Ritu. She is going to chair the session. Then senior madam, I think Zakia Khan madam soon she will join. And uh, Dr. Tabassum, she is also senior consultant cardiologist, and Dr. Ankita, she is our assistant professor at KM. So they are the speakers for the event. And Dr. Priya, she is also senior consultant cardiologist as a chairing the session. Okay. So Ritu, let me know. I think Shiba, can we start the talk or
Yes, yes, sure.
yeah,
Yeah,
yeah, yeah.
it's 7:02,
It's
and I
seven.
think
Yeah.
yes, yes. Please go ahead.
Yeah. Okay. Kumar, I'm sharing my screen.
Sure, ma'am.
Yeah.
Yeah, we can see Dr. Hidden.
Yeah. Okay. So it is a very wonderful topic, that vulnerable plug. It is, I think, account as a Achilles heel of coronary interventions. And as we know that atherosclerosis, it's a malignant disease. It is like a systemic disease, and it accounts almost 31% death globally because of the vascular complications leading by the atherosclerosis. And the most culprit one is the vulnerable plaque. And it is being defined in 18th century by the plaque, which is a stability, and it leads to occlusion because of the thrombus formations and the rupture. So these are the basic characteristic of any vulnerable plaque, which has a lumen occluding first of all, thin cap fibroma, the macrophages, and there is a neoangiogenesis, the large necrotic core, and it leads to calcifications, spotty calcifications, the TCFA, the thin cap fibronema, and the lumen diameter gets narrowed. So let's start, and it has different types, like a stable and unstable plaque, and that we will discuss in our further talk. How the stable plaque gives a favorable outcome, whereas unstable plug, that called as a vulnerable plug, it is like a hidden volcano. It can rupture, it can leads to catastrophic event like a myocardial infections, any major adverse cardiac event, and leads to a death also. And same thing happens in a calcified vessels also. It may lead to a stable or unstable plug, and it depends on the imaging. I think as Shiba said, the imaging as plays a very important role in documentations of vulnerable plug. So let's start with my case. I'm going to present two quick cases. One is the vulnerable plug in ACS, which is a really real villain, because ACS happens because of the plug and its event. It is like a retrospective. We see that vulnerable plug has either got ruptured, erosions, or a thrombus formations. So my case one is a young male who has 38 years, is a diabetic hypertensive. He had presented with history of right ventricular myocardial infarctions. The ejection fractions was well preserved, and the angiography shows there is a borderline mid-RCA lesion. This is the angio. You can see there is a haziness, but it was a borderline lesion. But as a patient, because this such kind of plaque, what to do next? Because there is a haziness and a borderline lesion, but we had tried to probe the vessels with the help of OCT. Okay, this is my OCT run. Let me focus directly to the disease segment. You can see there is a thrombosis. The luminal area that gets narrowed, and there is a lipid-rich core. And here you can see there is a lesion is tight, but it has a can you see? I can freeze it. That it has a ruptured tendency. So that's the reason we had to. I'll just show you.
We could see the ruptured plaque
Yeah,
and
It was classical
head
demonstrated.
thrombus as well. Yes.
Thrombus as well as a rupture.
Thrombus it was, yes.
Yeah, see. Okay. So we had stented the vessels, direct stenting, because thrombus burden artery, we don't do more of a plumbing job. It invites a no flow situation. So 2.75 by 38 Zion's prime we had implanted, and the result was good.
You did
Well
direct
appreciated.
stenting, right?
Yeah.
Stenting. Did you post dilate?
Yeah, we had to post dilate the middle part.
And
Yeah.
sorry to interrupt, but do you have, I mean, we have any TICFA, I mean, calculation there, or any macrophages, 40 new, something else in the OCT?
Yeah, the OCT, there was a thrombus burden.
I
and
saw
the-
that.
There
Yes.
was a erosion plus rupture.
Right.
That was, yeah. This is a well opposed time.
Mhm. Yes. Beautiful.
Okay. So young patients, that is my this thing. That even though it is look like a borderline lesion, we should not leave them alone. We have to take, because if there is a hidden rupture and all, they land up into having a recurrence of event. So we can't leave them. Lab system was absolutely normal. Okay. Now my another case. It is a stable angina, 60 years male, hypertensive, dyslipidemia, tobacco chewer. He had a class 2 angina and dyspnea on exertions was from last 6 months, and there is a recent onset worsening symptoms for 3 to 4 days, and this TROP-T was positive. His echo was absolutely normal, and this is the angio. I had given only frozen to save the timing. It was left system was fine, but you can see the distal RCA again. There is a 62% lesion with the haziness, and then we had done the OCT. But see, here it was a beautiful demonstration of a rupture plug. This images was excellent. It has a, you can see the large neck lipid pool with the rupture, and there is a big attenuations behind the ruptured plug. It is a thrombus or a calcifications. Uh, okay. And then we had to dilate the lesion with a routine 2.5 by 15 balloon and put the stent, and post stenting, the lesion was. So vulnerable plug per se, during intervention, it is not a challenging thing. Only thing is imaging plays a very important role in identifying. We can't ignore what we see. So we have to stabilize with the local, in a patient with a stable or unstable angina. If there is evidence of rupture, we have to put a neocap, although there is a thin cap fibroma, but we have to put a neocap to steal an aggressive medical management to prevent the further recurrence. So now the story about the vulnerable plug starts. that previously there was a misconceptions. Just a minute. Previously, there was a misconception only that we usually targets and hunt for the lesion and the ischemia. So in 1980, there was a concept developed by the vulnerable plug that not only the stenos vessel, but non-stenos vessel, non-obstructive lesions having a vulnerable plug or large lipid burden, they are also prone for the adverse outcome and the adverse event. The same thing is not only the patient plug related concept, but it has evolved over a time, even the patients related. The patients have all the factors which are vulnerable for having the event, and they leads to clinical and the subclinical atherosclerosis, and that leads to future ACS event and the prothrombotic milieu. So the history of Pollock evolution is it start with a fatty strip, but it gradually collect and may leads to erosion and the rupture and leads to further event. So this is how the progressions of the plug develop over a period of time. It may leads to either ACS, or it may that if the cap is getting healed or thick cap, that leads to a stable or chronic coronary syndrome. So, but the inflammation, calcifications, and the scar within the calcifications is a important milieu for this. And according to the lesion, how the lesion characteristic, that also plays a very important role in formations of a vulnerable plaque. It is more common in a type 3 and beyond, where there is a thick cap fibroma or a thin cap fibroma. If there is a thin, I think the cutoff is 65 micrometer. If it is a thin cap fibroma, then patient develop either erosion rupture. Erosion is usually superadded by the coronary spasm. So here there is a vascular stress is affecting the intimal lining or endothelium dysfunctions, and that leads to vulnerable plug. So this is how the evolutions of the thin cap fibroma over a period of time. If you give aggressive medical management, that leads to thick cap fibroma. But certain patients, they have a patient-related vulnerability or the factors that may lead to either thin cap and the future chances of erosions, rupture, or nodules, and the fibrotic plugs. And this is there are various trials which has been proven that what we see, we should not overlook. Meaning the combined OCT trial, here they had found that even in a patients with I can say a recent MI with a triple vessel disease, and they done diabetic patient even in a non-ischemic lesion, they found 25% at a thin cap fibro adenoma, and which are positive, and that leads to major adverse cardiac event. And so the vulnerable plug, meaning there is a triad of vulnerable blood, meaning high lipid lipoprotein A, the hypercoagulability, hyperhomocystinemia, increased platelet aggregations, or myocardium, absence of preconditioned myocardium, vulnerable for arrhythmias or ischemic changes. And this leads to, so the determinants are not only the local, but the systemic, the traditional risk factors and the circulating markers are responsible for evolutions of the vulnerable plug and its event. So my vulnerable patients are all, according to Framingham risk scores, all the high risk individuals with having morphological compositions over a period of time leads to the three basic mechanism, either a rupture, erosions, functional alterations, and calcified nodule. But when the plug is getting ruptured, the biomarkers, the mediators, they are released and they knocks the others. Meaning there is a like a release of various biomarkers, and that leads to again triggers the inflammations and biomechanics. So we have to identify the serological markers, the imaging tool to understand what is the vulnerable plaque and its I think morphology. So here the hunt is not only the ischemia, but the morphology of the plaque is very important to risk stratify such patients. So our patients, not only we have to focus the traditional risk factors, but the vulnerable patients, vulnerable myocardium, and the vulnerable blood. And that triad leads to near future, we can predict the near future risk of a future adverse event. And this is a very good diagram, how the dynamics changes, where on the black line is where the intrinsic and extrinsic factors leads to adverse outcome and the possibility of the rupture. And as I said, the high risk ruptures are thin cake fibroadenoma or intimal thickness, and the non-obstructive and the obstructive. Even though it is obstructive, it has been documented that they are high risk for plaque future adverse event. But even the non-obstructive extensive lesions, they are also prone. So what we have to search? These are all our trials, that if you want to scat on the thin ice, you have to be very sure that it is like a vulnerable plug is like that. If the ice is thin, whether that thin ice can take the weight of the scatters, and is there any chance of falling into it? So the role of imaging plays a very important role. And we can nowadays, I think, with the advancement in the imaging, you can be a very precise imaging, and not only the one imaging, but the hybrid imaging, like a OCT with near IVUS, like that. And you can be precisely virtual IVUS. So you can be precisely image.
अच्छा
Yeah.
and then I was also there only. Our follow-up was in Feb. So then
Will you unmute? Yeah. Yeah. So here the precision imaging is here you have to see your focus is to see the fibrous cap, the necrotic coat, how the lipid burden is there, and the lumen. And this thin cap is the major identical, I think, marker for all adverse effect, and the limit is less than 65 micrometer. So the IVUS and OCT plays a very important role in diagnosing vulnerable plaque. Even though the IVUS has a good power, OCT has the only limit. OCT is more better compared to IVUS, but OCT has a limitation in the osteal lesion. Osteal lesion, you can't be that sure. So here you can take a hybrid of near OCT. Near is a near infrared spectroscopy, where you can find out the lipid pool, and you can identify the future risk of adverse event. And this is how the artificial intelligence and the machine learning also plays a very important role in each level. The MRI is also plays a role, but here the MRI, the limitation is lot of motion artifact. The PET is more specific than the SPECT, but the SPECT with CT has more power to identify the inflammations inside the coronary. And these are the various trials which has shown that associations of a thin cap fibroadenoma or in a CT, the positive remodeling, the dilatations, the plaque volume, and the burden plays a very important role in predicting the future outcome. And this is how the evolutions of vulnerable plaque over a period of time. It may leads to either ACS or CCS. It depends on the plaque vulnerability. If it is ruptured or erosion, if it is being stabilized early and that leads to healing, then the patient may present with a stable angina. And this flow chart of atherosclerotic plaque depends on the risk individuals and the destabilizations, I can say, the vulnerable blood or vulnerable patients and the vulnerable myocardium leads to culprit plaque or a silent event. So the scatting on a thin ice there are chances of fall or going into the disaster. So we have to be very careful for identifying the thinness of the cap fibroadenoma and I think protect our patients for future disasters. So finally, we should, what are the high red flag signs? The high risk plaque. And they are like in the patients with positive remodeling, the inflammatory state, and the lesion morphology and the hemodynamic and the endothelial stress. The vulnerable plaque is being associated with increased cardiac event, and it is in the demonstrated well into the prospective. And here the more than 2 and the lumen area of less than or equal to 4. Even in the IVers, you have to, they had given a specific criteria that lumen, quantitative and the qualitative measurement of a plaque burden and the positive remodeling. So, according to the Birmingham risk score, we are usually risk stratify the individual depends on the traditional risk factor. But in such high risk individual, if we take a help of non-invasive imaging for the vulnerable plaque, then you can identify the high risk or very high risk. And if it is very high risk, then you have to prepare the patient for invasive tool, and then you can focus the re-stratify the patients, not only the local treatment but the systemic treatment by advocating a high dose of statin or PCSK9. These are the wonderful pictures of a histopatho about the plaque rupture, erosions, and you can see in erosion the intima margins are preserved, but in rupture it is a superadded thrombus and the luminal narrowing. And this is how the I can say that a culprit versus non-culprit, but what are the high-risk features? It depends on the thin cap fibroma. In the OCT, the lipid arc should be more than 90 degree. There would be a thin cap fibroadenoma, and the virtual histopathology. Also, you can see the deep layers of the fibroadenomas, and there is a extensive expressing the characterization criteria for plaque rupture is that active inflammations, the calcified nodule is presence, endothelial dysfunctions, positive remodeling, and the luminal stenosis is about 90%. So IVAS is obviously a good modality, but it is not a class 1 recommendations compared to OCT because it has a low penetration power, but you can see and it will be act as a added advantage for supporting tool to confirm the diagnosis. And these are all the CCTA imaging where we can see the plaque compositions, the plaque whether it is high risk or low risk, and the plaque attenuation. So qualitative, quantitative measure of the plaque. And not only that, but also we can identify the calcifications of the vulnerable plaque. And these are the very beautiful images about how, what are the findings on the CTCA, that uh, napkin ring signs, where it is a plaque with a ring hyperattenuations, the positive remodeling. In a patients with vulnerable plaque, the vessels compensate, it expands, and that leads to patent lumen with the thick vessel wall. And what are the high risk features which prone for the vulnerable plaque is a positive remodeling, then the low plaque density and the locations into the proximal vessels. The knee rivers is extraordinary. It has a very color code system. It is very high for the lipid burden to quantify the lipid pull into the vessels, and a plaque burden you can very well picked up with the near IVAS. These are the images of the yellow color indicates it is a large lipid pool compared to other. And this is how the uh, detections of a high risk plaque by near IVAS. And if you find, then you can decide the strategies, whether the patient will go only for GDMT or PCI with GDMT. And these are the various head-to-head comparison about the CTCA and the OCT. The OCT, the latest advantage is I think work in progress is about the cholesterol crystal. They are like a very immediate and it has a very positive predictive value, and that gives a very good signals to the OCT. And in the CTCA, as I said, the positive remodeling, low attenuations of the plaque, the napkin ring signs, and the spotty calcifications, they are the marker for identifying the vulnerable plaque. And depends on the treatment. We have to not only do the local treatment if it is a high risk for the rupture, but also patient needs a systemic, because it's a systemic disease. So if you seal the one vessels or one plaque, there are multiple plaques in the other vessels which we had not probed. So here the patient needs a aggressive lipid lowering drugs, and if there is a inflammation is been confirmed, then the anti-inflammatory treatment. And the OCT, hello, yeah, yeah. OCT has a high sensitivity and the specificity compared to other. It is almost 90 to 94% compared to others. And these are the three cardinal features of OCT. The calcified nodule is like a malignant disease of the coronaries. The erosion usually, as I said, is superheaded by the coronary spasm, and the rupture is a catastrophe. It leads to myocardial infarctions or sudden cardiac death. So in OCT, what we have to see whether the cap is disrupt or intact. If it is disrupt, then you are dealing with the plaque rupture, or if there is underlying calcium, then calcific nodule. And if there is a thrombus with intact cap, that means you are dealing with the plaque erosion. Now, the various differentiations, how the imaging modalities and its features, we can identify the vulnerability of the plaque easily. And what are the trials like Prospect 2 and other trials? They said, even though you are diagnosing the vulnerable plaque, but all the plaques you are not going to put a prophylactic stent. So you have to risk stratify whether you are dealing with the ACS or CCS. If it is CCS, you stabilize the plaque with the aggressive medical management, and functional imaging is mandatory, and the lipid lowering and anti-inflammatory therapy. If it is a ruptured and a superadded thrombus, then you have to seal locally with the stent. And this is how the risk-benefit ratio of vulnerable plaque. Not only you have to do the local and aggressive anti-lipid lowering and anti-inflammatory, but the thrombosis promoting factors you have to take into the account, and you have to treat that disorder too. So my last slide is the vulnerable plaque is a milieu or triad of ischemia, plaque vulnerability, and the plaque burden. So what we are going to look at, up till now we were hunting for the ischemia. Are we wise enough to see for the morphology of each plaque? I think imaging plays a very important role. But first, if you probe the vessels, normal healthy vessels, it is not good. So always do a non-invasive test and CTCA, exercise echo, the PAT, and you find out the plaque vulnerability, the plaque burden, depends on the calcium score and other issues. And then on the CTCA, you find out whether it is a spotty calcifications, napkin ring sign is positive, or positive remodeling, or low attenuations plaque. And then you stratify whether this is a future risk of any coronary events or not. And then accordingly, you have to treat the patients. So my patients with STEMI, you have to see whether it is erosion or rupture. If it is erosion, only antithrombotic therapy, but rupture, you need to do a PCI. But non-STMI depends on the risk profile. You have to customize the treatment. And this is the slide how the I can say the non-high risk plaque and the OCT, what is a vulnerable aspect and to prevent a future recurrence rate. And this is how you can pick up with each modality I can say that not only the 3K fibromas, but the lipid-rich plaque, the macrophage, the micro vessels, which are there are tiny vessels, because it leads to this plaque morphology leads to intra-plaque hemorrhage. So there will be microvessels formations, the cholesterol clusters, and the layered plaque. And the vulnerable plaques, the dilemma is what is the originally meant for the plaque, which is usually we focus the culprit lesions and the acute coronary event. But now it is the prevention is better than the treatment. And here we have to see and focus, risk stratify the chronic coronary syndrome too. And the patients with intrinsic and extrinsic effect are also taken into the account. And how we can interpret, I think still there is a lot of research going on, and we have to focus the thickness of the thin case fibroma, and we have to stabilize the plaque either medically as well as locally. Thank you.
Hi, Hetan, wonderful presentation. Just
Yeah.
one question. You said in PET scan for looking for inflammation, you specifically said something. I missed that. Could you
The
repeat?
PET with, because SPECT is not a good modality,
Hmm.
but the PET with CT, they are
PET CT.
picking.
Oh.
Only PET is not, and in acute setting, we don't recommend PET. We have to
Correct.
treat the patients. Yeah.
Right, right.
Yeah.
Beautiful presentation. Dr.
Thank
Zakia,
you.
I think
Yeah.
Dr. Zakia has joined now.
Yeah. Hello, madam. Yeah.
Good evening, and very
Yeah.
nice presentation, very detailed presentation about all imagings.
Yeah.
Now, my only question is, Hetan, that people are treating ACS in every nook and corner of the country, and not everybody has imaging,
Yeah, you're
So,
right.
when we are talking of an acute situation, say ST elevation and MI, most of the time you end up stenting because it's giving you ST elevation MI. There is the plaque is active. You know yourself looking at the clinical presentation of the patient. Only differentiation comes when it's an NSTEMI. You have the time to treat and you have the time to image such a patient. So can we broadly say that this applies more to NSTEMI than STEMI?
Yeah, it's a really very good questions, madam. Like, I agree that ACS, I think everybody, and now the imaging is also a costly tool. So we can't subject the patients and probe each vessels. But I would say the young patients, like even though it is a thrombus burden, if there is a catheter available, it is better to probe and restratify. But if it is not, then again, even in a non-STMI, the stenotic lesions you are going to, madam, put a stent, and irrespective of the imaging. But like a borderline lesion, and you want to restratify, and there is a patient-related factors, the myocardium is vulnerable, hypercoagulable state. In such cases, if there is a chance, you have to restratify with the help of imaging. Otherwise, you can't diagnose the vulnerable plug without the imaging. But in such cases, madam, I think CTCA in a stable patient, CTCA plays a role. You can restratify it further. Yeah.
Okay.
Yeah.
Thank you.
Good evening, ma'am. Tabassum here.
Yeah, hi, Tabassum. Yeah.
Ma'am, wonderful presentation. Actually, you covered everything about vulnerable plaque. I just have one question to say, ma'am. When it comes to vulnerability, it's always a problem with one diagnostic modality. May it be imaging, may it be CT, may it be PET. So do you feel that there should be some way or some combination of tests needed to actually prove the vulnerability?
Yeah, agree. I absolutely agree with you. There
But
should be a hybrid approach rather than the single. But again, the vulnerable plug itself has its own dynamicity. Like today, you had found the vulnerable plug, but if you find over a period of time, it may be healed, it may be stable, or it may be. So all vulnerable plug, we don't have to seal it. But if you high risk individual, if you can identify, you have to closely monitor and do a aggressive management in such cases. Yeah, but the hybrid approach is better to, because still there is a gray zone. You are not 100% sure
Sure
about
about it.
the because even the imaging, whatever the OCT and all, sometimes our eyes can't pick up that much aspect of the thickness of the cap or its vulnerability.
Because
So the
ma'am,
hybrid imaging is better. Yeah.
better. And now in Western countries, it's become a trend that people are doing CT calcium score.
Yes, yes.
Same is
Yeah.
happening with Indian population. Actually,
Yeah.
they have also started doing CT calcium scores and visiting us. Now, that is a very vague method of telling them that, yeah, whether there would be a problem or not a problem, because young population are generally worried about MI more nowadays, looking at the trend of young MIs coming to the hospital. So with
So
that,
I think, yeah, it's a very good thing. So my take-home message from this lecture would be like those who are having a calcium score of above 500 or increasing calcium score and the cholesterol level of more than 240, they are like a high-risk individuals and with a comorbidity. So yeah, you can't, you have to be work aggressively in such patients, irrespective of imaging or other things, to
okay,
stabilize the future event,
okay.
prevent the future events. Yeah.
Thank you, ma'am.
Hello, madam. Yeah.
Must be right. And I was like, taken away with your nice, beautiful.
Madam, your voice is not audible. Yeah.
Yeah, I have unmuted myself,
Okay.
and I think I should be able to. I think
Yeah,
I
we
have
can hear you.
unmuted.
We can hear you.
Yeah.
Okay. Today
Yeah.
only I
Now we
was
can hear you.
reading one article just published in European Heart Journal Cardiovascular Imaging, that is plaque analysis on the CT with the AI guided. And
Yes.
this
Yes.
is the reveal plaque trial. Today only it has come in that article. And they
Yeah.
have
Yeah.
compared with AI guided CT imaging, comparing to the IVA studies. That was in Japanese 237 patients along with some places of US also, 15 centers, and they have combined this analysis, and they have shown that the plaque, Jagat Narula and certain other authors are there, and they have given the IVAS reference standard measurements are very AI related. They can show us that exactly what is the cornerstone of the heart flow and the plaque morphology and the plaque vulnerability. So this reveal plaque issued a statement highlighting the results, and it shows that even CT angio with, if you have a AI algorithm incorporated into that AI related this thing information, then we can easily identify that which plaque is technologically assessment wise should be treated as a high risk plaque. So this is what is they are now looking at the initial statement of
Yeah.
the
This is
CT.
what I had. Yeah. It's. I agree with you. Madam, I had included that thing in my slide, that AI
Yeah.
with machine learning again
Yeah.
will give you more insight about the plaque morphology. But
Yes.
here, I like, as I think Ritu, Tapatsum and Madam says, in India, to go for high end, we have to, at present, we are having a clinical and the non-invasive test to focus and help our patients. Yeah.
Exactly speaking, that's
Yeah.
a very good point.
Yeah.
And we have actually started picking up very early at the
Yeah.
age of 20, 30, also very high risk patients, family history. We do this.
Yeah, so misconception of only a stenotic plaque is a reason for all the event is we should, I think we are now more wiser about understanding the plaque morphology, the patient aspect, the intrinsic and extrinsic, and we have to treat the patient because it's a systemic disease. If you try to focus only one vessel and one vulnerable plaque, but you are missing others. So you have to address the systemic disorders rather than the local.
The SLE patient just now,
Yeah.
today with lot of plaque burden, though he was already on azithromycin, still it has happened. So
Yeah.
inflammation is such a high risk condition along with this instability of the
Yeah.
plaque vulnerability.
Very
That's
good
a-
insight, madam. Now, can we move to another lecture, Ritu? We
Yeah,
can. Yeah.
So Tabassum is speaking about is the second speaker, right?
Okay.
I am
Tabassum and
speaking.
I think Ankita is also there. I think Tabassum, you can start your lectures. Yeah.
Okay, fine.
Ankita is there?
Yes, ma'am. Yes, ma'am. I'm there.
Okay. Okay. Yeah. Yeah.
So-
I'll stop my share.
Should I or Ankita
Yeah.
is presenting?
Yeah, I'm stopping. Yeah. Ankita, if you're ready, otherwise, whatever.
Anything
your
is fine, ma'am.
Ankita, you can present because your was the second on the list. Yeah. Yeah.
Okay.
Yeah.
Good evening, everyone. I would like to thank WINCARS and Hetan Madam for this wonderful opportunity to present in such a forum. And I'll just start sharing my slides. Okay, are my slides visible?
Yes,
Yes, yes, it is visible. Go ahead. Yeah.
Okay. So has Odyssey really changed the Odyssey of vulnerable plaque? I will be discussing the role of medical management for the treatment of vulnerable plaque. Although Odyssey has the most catchy name amongst all the trials, but there are many measures, pharmacological as well as non-pharmacological, which can be used to treat the vulnerable plaque, and hence I will be discussing all of them. Hetan ma'am has already discussed in detail about the vulnerable plaque. However, I would just like to reiterate a few points which I think are relevant. As we know, cardiovascular disease, it remains to be the leading cause of death worldwide. And this atherosclerotic cardiovascular disease actually begins with a plaque. This plaque is formed due to endothelial dysfunction, which could be secondary to sustained exposure to an unfavorable milieu, as ma'am has already stated, in the form of increased blood sugars, high wall stress due to uncontrolled hypertension, or direct toxic effects of smoking, tobacco, and other inflammatory mediators. This leads to recruitment of inflammatory cells and formation of foam cells at the area where there is increased permeability to lipoproteins, and there is formation of foam cells. Also, there is activation of vascular smooth muscle cells, which leads to the formation of this fibrous fibroatheroma, and there is a fibrous cap formation. If this is unaltered, the progression goes on to development of a stable fibrofatty plaque where fibrous component forms on.
Please
Sorry?
unmute everybody.
So this will be the stable progressive part of the development of a fibroatheroma, which can at any point in time be interrupted by plaque rupture erosion, leading to an unstable event. Since time eternity, we have known that it is the most stenotic lesions which lead to acute coronary events. However, the number of less obstructive plaques are so many. I mean, they are usually in majority, and hence in the long run, when we look at them, it is these non-obstructive, moderately stenotic plaques which should be the main focus for our treatment, since they outnumber the severely stenotic plaques by a great amount, and they will be the ones which will be leading to the long-term ACS events and long-term morbidity and mortality in our patients. And hence we go on to looking at the vulnerable plaques. As ma'am has already iterated, vulnerability of an atheromatous plaque is defined by the size and consistency of the atheromatous core, the thickness of the fibrous cap, presence of inflammation within the cap fatigue, and presence of calcium nodules. But before being able to treat it, we should first be able to detect it. So we have different imaging modalities that are now present, which are invasive and non-invasive. Invasive including the angiography, which has traditionally been used for many years. IVUS and OCT are now gaining significant importance. Also, another important modality that has emerged is CT coronary. Being non-invasive, this helps us to image the whole coronary tree at one point in time. Hence, it is a good screening modality. Also, the number of patients that can be recruited in various trials would be higher, and more number of plaques could be studied when using non-invasive modalities. These are a few differences this ma'am has already stressed upon. one important thing here is that now CT coronary angiography has shown very good correlation with IVUS and OCT features of the vulnerable plaque. And that is why CTCA is gaining further value in actually looking for vulnerable plaque in the high-risk population. So now whatever was responsible for causing plaque progression is also should be the target for our plaque treatment so that we can cause plaque regression. This includes decreasing the lipid content, then the macrophage content, and the inflammatory state. Traditionally, plaque regression has been defined as an increase in the luminal diameter on angiography. But lately, with the advent of OCT and IVUS, we also look at the plaque volume and the composition within the plaque. So these are the major modalities which have been used to target different mechanisms of plaque regression. So to reduce cholesterol and inflammation, we have icosapentaenoic acid, which modulates both, decreasing the lipid content as well as it acts as a precursor for several inflammatory mediators and therefore helps in reducing the inflammatory component of the atheromatous plaque. Also, colchicine has been significantly useful in stable coronary disease as well as in ACS. It has shown to reduce the plaque burden. The major part of this talk where we are talking about lipid lowering therapies in the form of statins, which is low dose as well as high dose statins, ezetimibe, PCSK9 inhibitors, and a few others, which will help lower the lipid content and thus help stabilize the plaque by decreasing the plaque burden. Then there are other non-pharmacological modalities in the form of exercise, diet, which even though have a heterogeneous kind of response, but they do help enhance the endothelial repair. They help in overall improvement in the cardiovascular risk profile and thus can also help in plaque regression. So I will first just stress upon the non-pharmacological methods. So diet, it has a major role in reducing the CV events through both decreasing the calorie intake as well as by just specific dietary patterns. Even though the plaque regression is not well documented, there were a few studies in the past which did show some amount of plaque regression in patients who were on a good controlled diet. These were through coronary angiography or CCTA images. The doubtful thing about this is the newer statin trials have shown that in the placebo arm, where there was only diet and regular follow-up, there was constant progression in the atheroma volume, total atheroma volume on CCTA as well as coronary angiography, and hence the dietary strategy alone has a doubtful role. Again, exercise, both primary and secondary prevention roles for CV events. There was a Cochrane review, including meta-analysis of about 63 studies, which showed reduction in CV mortality. A post-hoc analysis of these trials actually showed a change in, there was plaque regression in patients with more than 7,000 steps per day. However, the overall benefit is modest. We all know the constant presence of smoking and alcohol keeps on triggering the endothelium and causes endothelial injury, causing unstabilization of the plaque, and thus smoking and alcohol cessation plays an important role. Coming to the pharmacological methods, the train here is mainly driven by the high-intensity statins. These have time and again proven in multiple trials to be very effective in lowering the total plaque volume, percentage plaque volume, and also the number of ASCVD events. So this was the Japan ACS trial, which tested low versus high dose statins and showed significant change in the total atheroma volume up to -15%, which is the highest. Secondly was low dose statins with ezetimibe. in the Zeus trial, which showed almost a 13% reduction in the total atheroma volume. Again, as compared to a low dose, simply a low dose statin. And this was especially demonstrated in diabetic patients. I will elaborate further. The newer kids on the block include the PCSK9 inhibitors and inclisiran. They have also shown modest benefits when considering the total atheroma volume by about 3 to 5%. And they have obviously shown much benefit in reducing the number of ASCVD events. So statins, they have formed the backbone of lipid management since early 1990s. Their impact on plaque regression is very well studied, and they can cause a massive effect, especially with high-dose statins, from 0 to 20% in the total atheroma volume. There have been several observational studies in the form of Asteroid, Cosmos, and IBIS, which have demonstrated significant total atheroma volume reduction up to with 40 milligrams of rosuvastatin. Again, there have been several studies with ezetimibe, such as the Haven Zeus trial, the Precise IVIS. All these were IVIS-based studies majorly, and they have shown significant reduction in the total atheroma volume, being 2.9 to 13.9%. Although the reduction in the atheroma volume was numerically great, it wasn't statistically significant, but it was shown to be significant even statistically in diabetic patients. This has been stressed upon because there are chances of worsening of blood sugars and sugar control with high-dose statins, and hence low-dose statins with ezetimibe can be very well utilized in patients with diabetes where they show significant reduction in the atheroma volume. Then came the PCSK9 inhibitors, which again in the Glasgow study with evolucumab showed a significant reduction in the total atheroma volumes at 76 weeks. And the Odyssey Japanese study, where in ACS patients on OMT as well as with PCSK9 inhibitor in the form of alirocumab, it showed significant reduction in total atheroma volume by about 25%. Another benefit that is seen with PCSK9 is also a reduction in lipoprotein A, which may mediate some of the benefits which are seen in the plaque volumes. EPA is a newer anti-lipid agent, lipid-lowering therapy that has come, and it has impact in two ways. One is obviously lowering the lipid levels, but it also acts as a precursor for several anti-inflammatory mediators, and hence it helps in reducing the inflammation as well as the lipid core content. The other medications, as we talked about, considering progression is due to stress on the endothelium and inflammation. Other modalities for reducing the atheroma volume could be antihypertensives, colchicine, anti-diabetic medications, LDL apheresis. There are many more new medications that are coming into the picture. There have been several meta-analyses, of which I would like to stress upon this one. This was recently published 2023 in JACC, where several lipid-lowering therapies, multiple studies, up to 52 studies were included, and these were the lipid-lowering therapies that were tested. Of these, the maximum benefit, all of them did show significant decrease in the plaque volume, the lipid arc, as well as increase in the fibrous cap thickness. So overall, stabilizing what we are calling now a vulnerable plaque. And the train here was mainly driven by high-intensity statin. This was the showstopper, which decreased the atheroma volume by 7.6 and was the major contributor. Secondly, there was plaque modification even with low-dose statin and ezetimibe. This was atorvastatin. Also with low-dose statin and icosapentaenoic acid, PCSK9 inhibitors, and high-intensity statins. So the meta-analysis found significant regression of both percent atheroma volume and total atheroma volumes with lipid-lowering therapies. High-intensity statin was the most effective group. One peculiar thing about these studies was found that the reduction in atheroma volume was irrespective of the LDL lowering ability of these lipid lowering therapies. So high intensity statins, whether be it if they were able to achieve an LDL level of less than 70 or not, they did show a significant decrease in atheroma volume. Also, they showed significant changes in the composition of the fibroatheroma with decrease in the plaque content and increase in the fibrous cap thickness, which showed stabilization of the plaque. Also, there was some calcification and further calcific deposit, which was probably found to be a little troublesome. Then specific therapies I have already talked about. The clinical implications, however, have not really been there have not been studies that can correlate the decrease in plaque volume with the occurrence of MACE events, and hence further studies are required. And hence the ACC-AHA guidelines still recommend just targeting the LDL levels, and the vulnerable plaque per se or characterization of plaques has not yet been seen in the guidelines. So the significant plaque regression associated with lipid lowering therapies is observed mainly to be driven by high intensity statins. Other LLTs also significantly reduce plaque volume lipid arc while increasing the fibrous cap thickness. However, further studies are needed to determine the effect of plaque regression and content modification on the MACE events. Thank you.
Very nice, Ankita. Very clear and precise.
Yeah,
Dr.
but,
Hetan?
Dr. Ritu and Dr. Hetan, if you would permit me, may I just make a small little announcement? Because I thought this is the right time. We are in the mid of this. I'm sorry for interrupting, but I wanted to request.
We can't hear.
Shiba, somebody muted Dr. Shiba. Please unmute yourself. Yeah.
yeah.
Hello.
Yeah, we can hear you now, Shiba.
Am I audible?
Yeah, you're audible.
Yeah, I can't hear you, but I just wanted to make a small little announcement for all the speakers. Sorry for interrupting in the mid of the session, but wanted to request all the speakers to kindly share their slides at WINCARS secretary email.com,
because we want to upload this entire thing on the WINCARS website. So that would be very imperative after the meeting. Thank you very much. Please carry on. Yeah.
Makes sense. Yes, Ankita.
Ankita, it was really a good discussion. I just want to say the Odyssey trial. What is the Odyssey outcome trial? Can it be included in this lipid lowering therapy? And what are the criticism about the Odyssey trial?
The Odyssey outcome trial, again with alirocumab, ma'am, it showed a significant reduction in the ASCVD events with the use of alirocumab over the tolerated statin dose. However, ma'am, the problem with Odyssey was that majorly in applying in the Indian setup, the cost of these
Therapy is
PCSK9
quite high.
inhibitors is significant.
And this trial is not meant for determining the CV outcome trial. It was just for the LDL and
Lipid lowering.
lipid
Yes,
lowering. Second thing is about in this trial, the major limitation was the neurocognitive side effects, which has not been assessed properly. And even in the cardiovascular side effect, if major like a heart failure and all, it has been nullified with the other minor events. So these are the major limitations. So Odyssey will not change the Odyssey of lipid lowering therapy. That was the main issue. But you had nicely covered how the aggressive lipid lowering therapy helps in stabilizing the plaque. I think Ritu, you have any questions? Or
No,
yeah.
I totally agree with you,
Yeah.
and wonderful presentation. I really liked it, Ankita. I
Yeah.
think we could move to
Tabassum. Yeah. Yeah, Tabassum, are you ready? Yeah.
Yes, ma'am. Yes, ma'am. I am.
Yeah.
Is it visible, ma'am? My screen?
Yes.
Today, all the presentations which we are doing is on vulnerability of plaque. And I think PREVENT trial, which has just been published in 2024 and presented in ACC 2024 from South Korea, makes a huge impact on the treatment of vulnerable atherosclerotic coronary plaques, whether PREVENT trial is actually going to prevent vulnerability of vulnerable coronary plaques or prevent any cardiovascular outcomes. We really are not sure. So I'm going to cover these slides, which I have actually taken from ACC 2024, which was presented by the study coordinator himself. So I just took those slides because I found them interesting. So coming to the background, intracoronary imaging is very important to know the vulnerability of the plaque, and that is what has been done here. And depending on the imaging and other criteria, physiological assessment with FFR, they have actually divided in PREVENT trial, they have divided into the trial group into two. One where only optimal medical therapy was given, and on the other side where it was OMT along with PCI, and these were all non-flow limiting lesions. So basically vulnerable plaque labeled by imaging and by other modalities. So the background is OMT is standard approach to stabilize the plaque vulnerability. Safety and effectiveness of focal preventive PCI of non-flow limiting vulnerable plaque are still unknown. So this was the background on which this trial was conducted. So what was the objective of the trial? To assess whether focal preventive PCI of non-flow limiting lesions, because most of the time the question is whether we should stent or we shouldn't stent. So vulnerable plaques imaging plays a very important role, especially on table, because when we have taken any patient with who has presented to us with chest pain, non-ST elevation MI, here the basic question with the cardiologist is whether to stent this lesion or whether not to stent. So imaging defined vulnerable plaque improves the clinical outcomes compared with OMT alone was the objective to prove that preventive PCI works. So this was the trial design. The coronary stenosis was more than 50% with negative FFR, but meeting two of the following criteria. So like ma'am already has defined everything about vulnerable plaque. I'm just going through that. So what was imaging defined vulnerable plaque? MLA of less than 4 millimeter square, a plaque burden of more than 70%, which has to be proven either by NIRS or by IVIS, and TCFA by OCT or IVIS. And very important was lipid-rich plaque by NIRS. So NIRS is not more of subjective like IVIS and OCT. So it's more like color coding, and you just have to, like ma'am has already shown the images, on that you come to know exactly how lipid-rich the plaque is, and it is easier also to interpret. On this basis, they have actually divided this group into two. One was preventive PCI plus OMT and one was OMT alone. Equal number of individuals in both. However, few had crossed over later on. I'll just show you in my next slides. So primary endpoint was target vessel failure at 2 years, which included composite of death from cardiac cause, any target vessel MI, ischemic driven target vessel revascularization, or unplanned hospitalization due to unstable or progressive angina. The major inclusion criteria was age group of more than 18 years, angiographically significant stenosis of more than 50%, but with negative FFR. So physiologically it is negative, and meeting the criteria which I have already told you. Eligible for PCI, they have used both actually absorb BVS or was used, and everolimus eluting stents after absorb was stopped. Reference vessel diameter 2.75 to 4 and lesion length of less than 40 millimeters. Exclusion criteria, the patient whose preferred treatment was CABG, so multivessel diseases, previously stented lesion, any bypass graft lesion, patient who had 3 or more target lesions or 2 target lesions in the same coronary artery, heavily calcified or angulated lesions were not there in this, bifurcation lesions requiring 2-stent technique, contraindication of any antiplatelet therapy, discontinuation within 1 year. So procedure was initially the recruitment period of the trial. They performed PCI using a bioabsorbable scaffold. Following the withdrawal of the scaffold, cobalt chromium everolimus eluting metal stents were used, especially Abbott Zions. IVIS of all target lesions was performed. Patients were receiving dual antiplatelet therapy for at least 6 or 12 months after PCI, according to their clinical presentations and anatomical complexity. The clinical follow-up was done at 1, 6, 12, and 24 months and every year thereafter. And then follow-up continued annually in all the enrolled patients until the last enrolled patient reached 2 years after randomization. So this was the procedure, how it goes. So look at the angiographically, it looks 70%, FFR was 0.83. Then various imaging modalities were used where it was found that the MLA is 2.11, plaque burden was 79%, TCFA was found, and there was a lipid co-burden index by NIRS of 573. The absorbed stent was used. And the primary endpoint, as I've already talked about, was a target vessel failure. So any death from cardiac cause or target vessel MI or target vessel revascularization or hospitalization for unstable angina at least 2 years after, at 2 years after randomization. Secondary endpoint was any individual components of primary composite outcome or all-cause death, all MI, or any repeat revascularization, any procedural safety outcomes, stroke, bleeding events, and number of anti-anginal medications used at each time point. That means if the patient has a progressive angina. So they started with 5,627 patients with intermediate stenosis of more than 50%. This trial was started in September 23, 2015 to September 29, 2021, 6 years. After that, 2,065 patients underwent revascularization with positive FFR. So they were left with 3,562 with lesions of stenosis of more than 50% and negative FFR. Here also 1,954 were not meeting the imaging criteria of vulnerable plaque, so they were excluded. So ultimately left with 1,600 randomly assigned patients, and imaging criteria, they all fitted into the imaging criteria of vulnerable plaque, and then they were optimized either to optimal medical therapy or preventive PCI plus optimal medical therapy. Later on, what happened was, out of 1,600 patients who were randomized to 800 and 800 of OMT and preventive PCI, the ones in preventive PCI, 6 withdrew the consent at less than 12 months, 17 were lost to follow-up, and 74 crossed over to OMT alone. On the other hand, on the OMT side, 2 withdrew consent, 25 were lost to follow-up, and 12 crossed over. So ultimately, 780 were in the preventive PCI group and 776 in the OMT group. The baseline characteristics was, or the age group was around 60, female and male, female sex was around 200 in both. BMI was adequate. Diabetic patients were included. Hypertensive patients were included in both the groups. There was dyslipidemia. Smokers, previous PCI, there were few, 14%. History of CVA in the past were also around 50 to 6%. And clinical presentation was very important. Either there was stable angina or silent ischemia in both the groups. Unstable angina were little on the lesser side, 100 year and 91 year. Non-ST elevation MI, again 2% year and 3% year, and ST elevation MI were 1% in both the groups. Anatomical characteristic, as I told you, the qualifying criteria for target lesions, for both it was the same. The MLA of less than 4, plaque burden more than 70%, and lipid-rich burden index of more than 315, and TCFA either defined by OCT or IVUS. Mostly it was LAD territory lesions. LCX was the lowest, and second was the RCA. Median FFR in both the groups were normal, and the QC of target lesions, the diameter stenosis was less 56% in preventive PCI and 52 in OMT. Minimal lumen diameter around 1.5, reference vessel diameter of 3, and lesion length was less than 40. So ideally it was around 24, the short length lesions. The core lab imaging analysis, again, there were IVUS measurements done for the lesion length, the luminal area, the luminal stenosis, and the plaque burden. So very important criteria was the plaque burden of more than 70%. And NIRS measurement, LCBI of more than 315. TCFA was defined by IVUS, but that was only 57 in preventive PCI group and 17 OMT alone. OCT measurements done was TCFA defined by OCT, around 11 in preventive PCI and 7 in OMT alone. Then procedural characteristics, again, as I told you, they started with bioabsorbable scaffold. So around 200 patients were with bioabsorbable scaffold, and drug-eluting were more, that is 500. Then the number of stents in each patient was around 1 of 3.5 millimeter as an average diameter and length of 23 millimeter. The safety outcomes, patients without non-target vessel PCI, so the total PCI time was around 30 minutes. Contrast media, they took care of all the safety precautions, was 150 and not more than that. So this was basically the safety precautions taken during the procedure. Now, very important is the primary composite outcome, that is the target vessel failure at 2 years follow-up. So definitely it was found that preventive PCI plus optimal medical therapy was 0.4 as compared to optical medical therapy alone, which shows that preventive PCI was beneficial to these patients. Same at 7-year follow-up, if we see the comparison between the two, it was again found that preventive PCI plus optimal medical therapy was much better as compared to optical medical therapy alone. Now, that was the primary composite outcome. This is patient-oriented composite outcome. That is death from any cause, any MI, or any relative risk. Again, it was found that in optimal medical therapy, the death ratio was higher as compared to preventive PCI plus OMT even after 7 years. So the graph starts right from the zero year, I mean the time of enrollment in the study. And then comes the individual components. So if you compare the individual components, the one on the right side, which is seen in red, so that is at the primary composite outcome at 2 years. So if you see that initial 2 years where the patient was actually PCI with OMT showed a better outcome as compared to the one who were only on optimal medical therapy alone, that was only for the primary composite outcome. Death ratio, target vessel related MI remained the same in both the groups, almost the same. Then again, ischemia driven target vessel revascularization, if we see again with the red, I'm showing it here on the right hand side, that shows that again preventive PCI plus OMT was better. That means at 2 years, a target vessel revascularization for preventive PCI plus OMT was only 1 patient as compared to optical medical therapy, which was 19 patients. So that was significant. And for unstable or progressive angina, recurrent hospitalization, again, optical medical therapy patients were higher as compared to those who have undergone a preventive PCI. Then coming to the secondary endpoint outcomes, from both the groups were almost equal. There was nothing, not a major significant difference between both. Coming to definite stent or scaffold thrombosis was not very high at 2 years, 4 years, and 7 years in those who have undergone PCI. Stroke was equal in both the groups, and bleeding events was almost the same. So what does the PREVENT trial shows? On the right hand side, we see the graph, which is all favoring that preventive PCI is better. So even including the age, the sex, whether patient has diabetes or not, ACS episodes, PCI of non-target vessel, median diameter stenosis by QCA or FFR, and intracoronary, IVUS and IVUS and NEEDS criteria and OCT criteria, all favors that preventive PCI had done was better as compared to optimal medical therapy alone. But there were certain limitations, study limitations, which was found that number one, it was an open label trial introducing the risk of placebo effects and ascertainment bias. So which patient will go for optimal medical therapy and which will go for a preventive PCI? It was a bias. It was the decision taken by the operator. Observed rates of primary outcome were substantially lower than expected in both the groups. So we found that there was not a major difference in the primary outcome. It was lower in both the groups. The selection of imaging modality to assess the plaque vulnerability also was left to operator discretion. So some must have undergone NEEDS, some IVUS, some OCT. It was not a combination of imaging modality done in these patients. 9% in the preventive PCI group and 1% in only the medical therapy alone group crossed over. So there was a crossover also. The 9% patients from the preventive PCI went for optimal medical therapy and 1% from that to 9%. So if you see, the more patients crossed over to optimal medical therapy alone, they did not collect data to examine the cost effectiveness of a preventive PCI strategy, because definitely imaging modality for Indians, it becomes very difficult to actually convince a patient to undergo multiple imaging modalities and then decide whether it is vulnerable or not and then go for stenting. Dual antiplatelet therapy use was greater in the preventive PCI group. So we know that when we have put a stent, all the operators and doctors are more stringent in giving them proper medications and taking care of the stent rather than only the OMT alone. So these were all the study limitations which I found in PREVENT trial group. So exactly whether it was only the stent or whether it was OMT also with PCI which took care of the vulnerability of the plaque. So a summary of key findings is that the PREVENT trial is the first large-scale trial where they have actually head-on comparison done between preventive PCI plus OMT versus OMT alone. and that too in non-flow limiting imaging defined vulnerable plaques. Second, in the PREVENT trial, preventive PCI definitely reduced the risk of death from cardiac causes, target vessel MI, ischemia-driven TBR, or hospitalization for unstable or progressive angina at 2 years. Preventive PCI also reduced a composite patient-oriented outcome of all-cause death, any MI, or repeat revascularization. And one very important thing was that the benefit sustained throughout the 7-year follow-up period. So it was not only initial 2 years, but even till 7 years, they have done good with preventive PCI and optimal medical therapy. In the PREVENT trial, it was proven that preventive PCI plus OMT resulted in lower incidence of MACE as compared to OMT alone in patients with non-flow limiting vulnerable plaques. Our key findings might provide novel insights on the role of preventive PCI in non-flow limiting high-risk vulnerable plaques in the future. That is what the study actually was done for. Thank you. And this is a link if somebody wants to go through the trial. Thank you so much.
Thank you. Thank you, Tabassum. It was really excellent, and you had conveyed the whole message about the PREVENT trial. But there are a lot of criticism about this vulnerable plaque because it is too early to do the prophylactic stenting. And that is one major, and the number needed to treat, like one patient needed it at 2 years, it's almost 45, and I think 7 years, it's almost 87. And the second last point I would like to add is, here they are not defined with the non-invasive tool also, the vulnerability. They are just focused the lipid burden. So the vulnerability still they had not profiled. So it is not only the message from this trial is, it is not only the prophylactic stenting, but you have to add on the high risk individual, the aggressive lipid. I think Ankita has covered very well that lipid lowering plays and the PCSK9 was used only in a 3% of the cases. So it was a very limited knowledge, but I think we need a long-term such study to define the vulnerability and stabilize the plaque in a better way.
I agree with you, Hetal here, but at the same time, I think this is the first trial where
so we need
not a very critical lesion was stented, and it was not a negative trial. I think this is the first time in the era of ischemia trial and courage trial. This was the first trial, and it's a long-term trial. They have studied the patient for 7 years.
7
And
years.
graphs are definitely
So up till now, the trials were on the ischemia focus. This is
absolutely
the vulnerable plaque focus
vulnerability.
trials.
Vulnerability.
Yeah.
So it's a
Still,
very
it leads, and what happened, like such a long-term trial, na, once they start including the patients, over a period of time, the new invention, new therapy comes into the market. So that's why the results we have to take into the baseline
But
characteristic.
Hetal, at the same time, even the OMT patients received the same therapy,
Yeah.
The benefit was given to both the groups, medical management. So I think it's a
But
real
would you do, Ritu, in your practice, prophylactic stenting in
No,
CCS?
no, we don't. See, definitely we don't. But unless, but as you showed in your cases definitely showed angiographic stenosis as well.
Yeah, young
But
patient, I would take in a way, plaque
Yes.
morphology is very important.
In ACS, when you see the vulnerability, I have seen in multiple cases the prox LAD, I would not hesitate in stenting, and I have done a couple of patients where I was very sure the lipid burden is huge, the risk stratification is huge, and it is an osteolenity, something like that. So I think time is not far if we are studying the patient and OCT is
But my patient was having a plaque rupture, not only the balloon.
And
but
yours got showing even angiographically. It wouldn't have been wrong in your case to stent them without imaging also, because they presented ACS and you could see the stenosis.
Haziness and
hazy. So Dr. Zakia.
Zakia madam will give us highlights about this.
Excellent article actually chosen.
Yes, very right, Dr.
Zakia. That today is a hot topic about this. Yeah.
Dr. Sujata is also there. Sujata ma'am.
Sujata madam. Hello, how are you?
So I have certain, right, this is a very, very interesting trial. But I have certain, they have chosen very, very unfortunately, they are low-risk patients. Stable ischemic heart disease, 83%, where the vulnerable plaques are less. It's not acute coronary syndrome patients. And as you have said, there is a huge play of dynamics. It's not the vulnerable patient itself. As you have rightly pointed out, there is the vulnerable patient, vulnerable plaque, the vulnerable myocardium, and we have excluded acute coronary syndrome patients. And the other
female population was only
25%.
As always.
And they excluded high-risk patients like bifurcation, more than 2 target lesions. Like you again said, it is a systemic thing. It's not that you will find one target lesion. That's one point. And the other point was a single stent was used. The dia was 3.5. The length was 23. I mean, where it's basically
this trial was to study the bioabsorbable scaffold. But it was only less number compared to others.
So they wanted to show that in young patients also, if you use BVS for a vulnerable plaque, and for a longer term, it won't make a difference. So they started with actually BVS, but then since it was withdrawn from the market, they had to use
And one major, this thing is, according to ESC guideline, the CCS, you don't intervene only.
Exactly.
Yeah, exactly.
So this is totally
That's
contradictory.
my biggest,
ACS, I agree.
But so ACS patients, ma'am, generally we also think if there is any plaque rupture or lipid burden is high, definitely we stent. But these all patients are stable patients, as ma'am also told about. So in stable patients, first of all, whether ask them to go for an angiography for Indian population becomes very difficult. Maybe, there for screening purpose also patients do angiography.
My strategy is like CCS, I do CTCA. If there is a proxality, left main, TVD, then only I will intervene. Otherwise, I'll continue empty. Yes.
Sabsam, I would also like to draw your attention that the primary endpoint was driven by not hard endpoints. The primary endpoint was driven by ischemia-driven target lesion revascularization. And the events were very low. So these are all my concerns in this trial.
Correct.
And just as there is a lot of discussion about this vulnerable plaque and all, while reading all the articles and I found like FFR positive, it is a one size fit for all. Okay. But FFR negative, and there are like a Vegas trial and all, they said there is a 25% future risk, even in FFR negative with high lipid burden artery. So we should be more wiser with such future trials, that whether we should plug locally stabilize and systemic aggressive treatment in such cases.
Correct.
Dr. Tripti, madam, you would like to?
Dr. Tripti, you are muted. Dr. Tripti, please unmute yourself.
Thank you. I have a point to say here that though we are targeting mostly LDL, and we say in Indian Lipid Association target LDL reduction should be less than 30 milligram per deciliter to prevent the future events, right? That is what is our Indian association, they say. But what about the lipoprotein little a? Now the extended risk factor, irrespective of LDL, is lipoprotein little a, which has come in a big way in
it
the
is
Indian
little a, but now creating a big problem.
Big problem because we have very high risk patients. I have seen many patients, those LDL we have reduced, but they have extended risk of recurrent coronary events. And when we have checked the LPA, though they didn't have a very high risk family history and all, LPA was high. And then we had to target the LPA treatment to prevent the further occurrence of the recurrences, though they were not having a very high risk culprit vessels and the lesions, but recurrence were very common. Once we do the culprit vessel stenting and we leave the non-culprit like less than 50%, less than 60%, we don't do imaging for all the lesions at a time, but sometimes we do FFR, but they do come back with the high risk events. And then we have checked the LPA and we found they have really high risk LPA, more than 90, more than 120, sometimes more than even 200. So these patients are at really high risk. So what to do for them? And they are all young patients. They are not very old patients. And they have LPA and we are not checking LPA. That is our problem. And now we have the medicines. Now we have the injections in inclisiran to reduce the LTA very drastically, almost 70 to 80% reduction. Along with, of course, as we have PCSK9 inhibitors, but they reduce by 25-30%. But now, to reduce almost to 70% LPA. And that
Very good
has
message, madam. Yeah.
shown the output benefit, but we can use it as a definite marker for the LPA at least, so that we can show in our young patients, yes, treating you for a proper guideline directed treatment. That is what I want to say.
Very right, very right. Dr. Tripti, point taken. Dr. Zaki, anything you were saying?
Tabassum, excellent, to the point, very crisply presented trial. Of course, all of us have its criticism, all of us have taken its positive point. But Hetan, I think full marks to you for selecting this topic and giving full justice to the topic by presenting good trials, good cases. And I think as a clinician, what I generally do is I listen to the patient. Even if there's a plaque, which is 50-60%, and the patient continues to have persistent angina, that is a patient I would study further. If a patient who's not having angina has a 50% block, many times I don't study that patient. But a person who remains symptomatic is the one who I go ahead and investigate further, do a OCT, do further evaluations like FFR and other things. So I think we should also be a little more clinically driven rather than only investigation driven. Thank you.
So such trial, I think, clears our misconception that only stenotic vessels are responsible for all milieu. That's a major take-home message from this. Yeah. Kavita, hi. Are you there? She's not around. I think we can conclude the session, Ritu.
Yes.
I think Madam had given a final gist. I think. Thank you, everyone. Thank you, Tabassum. Thank you, Ankita. And for wonderful presentations. And thank you, Ritu. Thank you. Kavita, hi. Would you like to say something? Okay. Are you busy? Okay. Okay, so we conclude over here. And thank you, Zakia Madam, for your presence and give your thoughts about this. And thank you, and we keep meeting in this platform again.
See you all in the next meeting. Yes.
Yeah.
So before we all leave,
very good. Yeah. Shiva,
so I would like to
Okay.
congratulate you, Hetan, and of course, the chair, Ritu, and all the speakers, Tabassum, Ankita, and I'm missing out one. Who was that, Hetan? It was you. We started with you. Yes, of course. And I think I missed out someone, but it was really an amazing talk and very nice insight. And you're very right. There was a time, we used to go to our teachers and, go to the patients and they would say stent this 90%. We used to say chronic stable angina. But it's actually those 30-40% lesions and 40-50% lesions. And now we have these modalities to pick up the vulnerable plaque. And with this PREVENT trial and all the discussion and the interaction that it has, kind of generated, I think future is the way. But at the same time, as would conclude that Dr. Zakia said, and all of us do it in our clinical practice, that it is the symptoms which drive us to the final management of patient. But I would like to congratulate all of you. It was thought-provoking and we really enjoyed this session. Congratulations. But as it is, I would again try to drop in a reminder. Please do drop in your slides to the because what happens is that we miss those slides later on and we get so busy. So this is the time. Please drop in your slides to WINCAR Secretariat so that they can be uploaded with your names on the website. Thank you so much and heartiest congratulations.
Thank you.
Thank you. Bye-bye. Bye-bye. Bye.